Fiona Almeida. Today I have the honor of introducing our very own Wellesley College alumna, Miss Ophelia Dahl. She graduated Wellesley College in 1994 as a Davis Scholar. And she majored in English. Wellesley College is dear to Miss Dahl, and she is a great asset to our community, and we enjoy having her come back to Wellesley College. Ms. Dahl is a writer, philanthropist, and a healthcare advocate. She is the co-founder and trustee of Partners in Health and currently serves as the executive director. Since 2000, she also served as the chair for Partners in Health. Under Ms. Dahl's leadership, Partners in Health forged groundbreaking successes in treating diseases of the poor and promoting health and human rights in areas of the world that have been ravaged by political conflict, poverty, and international neglect. Ms. Dahl was the 2006 Wellesley College commencement speaker and received the Alumni Achievement Award in 2008. I thought it would be appropriate for us Albrighters to use a quote from Ms. Dahl's 2006 commencement speech. Quote, "At roughly your age, I had an experience upon which I have been able to build my life's work so far. This can happen to you at 12, 31, or 81. Maybe it has already happened. The key is to live with an exquisite openness to the world, to not close any part and to let it all, including suffering of others, reach you. It doesn't have to be global health or social justice or fight against poverty, but it helps. It can be marketing, academics, law, medicine, athletics. But my wish for you is that you can find your passion, your abiding interest, and dedicate yourself to achievement in that area. The world will align around you." Please join me in giving a warm welcome to Miss Dahl and to another Wellesley alumna who graduated Wellesley College as a Davis Scholar in 2010, Amy Hussein. Welcome.
Thank you. Thank you, Fiona, for that lovely welcome. It's always good to be back. Nice to see you all. Nice to meet you all. I love coming here. I've been doing this for a few years now, and I actually just remembered this morning that actually today is January 10th, which is the anniversary of the earthquake in Haiti 4 years ago. And I was due to speak here, I think a day or two after it, or something like that. And it was one of those experiences where we were, as an organization that works in Haiti, we were very caught up in the whole thing. And as you can imagine, many of us felt it was sort of rearranged. And so at first I thought, oh, I better postpone coming here and we'll do it another time. And then after speaking with Joanne and others, I thought actually it would be just the thing to do. And it was. Coming back here, I think one of the things that it did is, as it does every year, is it is grounding, it is settling, it is good to be able to be here and to talk in the midst of other things that go on. As you all know, I'm sure that this is like, this is a day and age in which we're quite reactive. We're busy, we're reactive. We can even create more busyness than than one even needs. In fact, you know, one of the things I'd like to say to you, in case I don't get a chance to say it later, is just make sure that you make space for all kinds of things. Reading, connecting, all of that. So thank you. Thank you for inviting me here to speak to you. And I'm looking forward to, certainly I have a presentation, I've got some things I want to say, but I'm also looking forward to our conversation. That's my favorite part of this whole thing. And one of the things often is to sort of, really choose what it is I could talk about, because this big topic of global health, it covers a lot of things. I did have the chance to look at some of your bios too, and you are a wide and varied group of women, and it doesn't surprise me at all. But I was interested by the fact that all of you are brought together because of an interest in global affairs. But you're from, I think, Hong Kong and South Africa. There's somebody from Middlebury, Connecticut here. I mean, there's all of these different places, and they're broad and far. But I really, really hope that the places that you visit, that you'll go to, familiar and unfamiliar ones, because I know that those places could really, really use your engagement and your attention. Eventually, not now. Eventually. There's a lot of time. You guys often think, you know, oh, I got to do all this quickly, now. And one of the things I want to say is, this is about the long view. This work and life is really about a long view, and that's a piece of what I want you to take away. So so thinking about this in terms of landscapes, that would give us a chance to also talk about the view, the long view of this, the landscape. You know, so many ways so many lenses to look at this. But this is a landscape that I was very familiar with, and it's the landscape that I entered into as a young person, as Fiona said. And this is central Haiti, where I ended up really, you know, not through any fantastic planning or anything like that. I went off to see a little bit of the world, ended up a bit flukily here. Lots of sort of fortuitous things happened, but this is where I ended up, and it's right in the middle of central Haiti. And as you can see, it's extremely barren. These are all mountains, and you know, there's a few trees here and there, but this is a very dusty area. And one of the things that, you know, as we look at this, and as I think about this, it was rather a daunting place to end up, actually, as a first place to visit. But this is, you know, this is where I met a lot of people, and this is where the work began. And I think that, you know, speaking about broad or narrow, it was important in many ways for me as a young person who was meeting other people, particularly my good friend Paul Farmer, who ended up right here as well. And we, with mentors around there, were able to say, how can we make sure that we take a look at this one small area, this one small thing, not the entire problem. Obviously, you know, I probably don't need to stress to you how many issues there are in a place like Haiti, which is, you know, has some of the worst health statistics, certainly in the Western Hemisphere and also in the world, and so close to the shores of the United States. So that's an old landscape I'm familiar with, and I want to show you a new one. And the slides that I've selected today, not that many, but each one feels like I could talk to you for a couple of days about each one and get your feedback and thoughts about it. This is actually almost the same place. It's only about 20 minutes away by car. This is now a finished teaching hospital that we recently built, actually post-earthquake, with some of the funds that we were able to raise after the earthquake. And this was just if you can imagine this was just like this. This was an area. And this is a teaching hospital. So, you know, just to recap. So this is where we started off. We began building a small clinic in response to the community who asked us to respond to, you know, medical needs and that sort of thing. And then 25 years later, this is what we all ended up building. And I want to convey to you that this is a big team of people. You hear me speak. I am one of many thousands of people, and all with all kinds of different nationalities and skill sets to be able to get to the point where you can build this. And I'll talk about some of what that is. But this represents a change in landscape. And there's 25 years or so between those two pictures. And I think it's important to note that there is a big difference. When 25 years ago, there wasn't a big field. I mean, certainly the folks who know a lot more about some of these things can correct me too, but there may have been interest in global health, but even then it was relatively small. I remember my friend Paul Farmer telling me when he started medical school in about 1984 or so, and he said that there were, and I remember this, there were about 4 other people in his big medical school class who were interested in what would be called global health issues. So people who are interested in venturing out of the usual confines of the economic situation. So, you know, much more interest now. That's how the landscape changes. This is the good news. Far more interest. Universities, all sorts of groups are getting interested. There are many greater investments in global health these days. There's over 30 billion in the last few years have been invested in global health from all kinds of different sources. There's new funding vehicles that have been created, which is important because I think that there is a much more interest in the idea of what global health is. And just let me be clear, when I say global health, it doesn't mean outside this country. It really means anywhere that there are vast disparities. So we actually address global health in this country too for all kinds of reasons, and certainly we can get to that in the questions if you like. There's been progress in technology. There's been progress in all kinds of therapies. And I think there's been also a paradigm shift, which is key as well. So, you know, only a decade and a half ago, or even perhaps even less, actually, it was quite difficult to get people to really address some of these very important problems. So I'll take HIV, for example. When this all started, it was very, very commonplace to hear people say it's really too complicated to treat this kind of a treatable disease, but in settings of poverty. So, you know, I think we have to look at what that means in terms of standards overall. Why is there an entirely different standard here, or in, you know, pick your developed country in Europe or anywhere else in South America? Why is there a different standard? Why would we all, as a common humanity, say, okay, so one thing, HIV should be treated here in the United States, but it's really too complicated to treat over there? That, I don't hear that anymore. So this was something that we used to fight, and certainly the activists fought it extremely, extremely well and very, very effectively. If you want to study some, look at and study movement building, have a look at actually what the AIDS activists were able to do to procure the antiretroviral therapy and that sort of thing. But it's really amazing. So we've gone from, it's too complicated, it's too difficult, you know, even don't want to disparage anyone, but there was a real lack of imagination. You know, African people don't have the same concept of time, therefore, if they were to have to take their medicines, they would take them irregularly. It wouldn't be the same. That would increase the risk for resistance, etc. You will hear in your lives, whatever it is that you do, 100 different reasons why you can't do something. And I really, really want to stress to you all, don't believe what people say necessarily about anything. It doesn't have to be global health, but just challenge all of those common assumptions all the time. Say when people say, yes, it's really not, yes, it's a great thing you're thinking of doing, but it's really not possible. Challenge that and say, really, why? So tell me why. And it'll be a very interesting, I think it'll be a very interesting thing. So that's a little bit about the landscape. Things are looking better in many respects than 25 years ago, but there are still some big challenges. And this is, you know, this is a picture that might be, or similar pictures of this this actually happens to be what's referred to as a sort of tent city after the earthquake. It's a slide the other day as I was going through slides. I looked at this one and I thought, you know, if we talk about what some of the challenges are, this isn't, you know, a lot of people wouldn't see this as a medical challenge, and of course it is a health challenge, of course. I mean, I'm sure you all don't need persuading that that's the case, but also you don't have to have an earthquake in a country to know that there are housing crises and, you know, access to shelter, which is an enormous problem. Again, different set of assumptions that it's okay for some people to live like this, but it would be an outrage if that was going anywhere else. So I just want to pop back to this to make sure I've covered. So yeah, so there's the low standards and expectations. There's a big delivery gap. You know, one of the things, I'll talk about this, one of the things that Partners in Health is, we're really a healthcare delivery organization. There's a delivery gap. There's a lot of interest and research that goes on in a lot of these rather complex problems. There's often a gap in what it will take to actually deliver the new therapeutics, the new science, the new research, the fruits of the research, to actually get it into the communities. And that's an issue. The efforts to do this are highly disorganized, highly disorganized. So there's a large number of very, very good, and many of them effective NGOs. You may even know some of them. You may belong to some of them. You may support some of them. But on the whole, NGOs don't work with the governments and the public sector. They refuse to, for all kinds of reasons, and some of them definitely understandable. In the end, though, what you're going to do is create tons and tons and tons of parallel systems and many, many unregulated groups that are not really working together. And some of them do try to work together, but many of them don't. So, in Haiti, we had a lot of people helping us, and we did a sort of informal count, really, of the number of NGOs that were there at the time. And there were more than 10,000 NGOs in this relatively small country. The only place that has more is India of NGOs. Very, very, very few countries in the world actually, make an attempt to regulate them because they bring in huge amounts of capital. And it's a very interesting topic, again, one that we could go down for several hours, and I'm sure I could learn from you about. So there's the disorganized efforts, and there's the funding streams that take place. A lot of the funding is siloed. There's, the way funding takes place is to support efforts around mosquito nets, for example. There's hundreds of organizations that just do one thing. It's really difficult to just do one thing when you're already working in a situation of extreme poverty, because not that it's not well-meaning, but it's not particularly realistic to say, if you're living in destitution, but we give you a mosquito net, yes, it will help with that. I mean, there's lots of barriers as to why that might not work, but that's as you can imagine, that's an issue. We are holistic, complicated human beings, and when we get sick, even if we're not living in poverty, it can be very, very, very complicated. Paul said to me, one patient can be devastatingly complex. Think of one person who's been very ill, and think about what was needed, all of the systems to support that one person, let alone an entire group of people who are living in destitution and are very, very vulnerable to disease. And then I think sort of most importantly, there's a great failure of imagination. That's a huge issue, and it goes back to this piece I was talking about with respect to just lower standards. Somehow, although we have, certainly as a nation and many nations, the ability to build extraordinary things. There's all sorts of things around the next corner, but really, when it comes to finding innovative solutions for people who are living in terrible conditions, I can't stress this enough, and I know you already know this, but it still strikes me all these years later that it's astounding that there is this huge difference in our own landscape, that so many people, it is an outrage, of course, but it's amazing how there's this disconnect from that. So is it, what is it? Is it a failure of imagination? Is it that people feel disconnected? Is it that they don't feel empowered to be able to do something about it? Is it that they take the sort of path of least resistance? What are the things that contribute to that? But even when people go into this kind of work, so let's just call it social justice work, whichever, it doesn't have to be through health and medicine, any of the things that you are working on now and studying around infrastructure, water systems, that sort of thing, making sure that there is, not failure of imagination, making sure that people can say what is needed in order to be able to do this, and keep on going until it is, and not say, I think we can come up with just a water filter, that should do it, when actually what's needed is a municipal, well-connected water system. If we have time, I'm very happy to go into that, and sort of with questions and that sort of thing. So, that is a failure of imagination. It's a broad, big topic. So this is a slide about, just very briefly, it looks as though someone who was, in charge of Partners in Health took a dart and just threw it at a dartboard. It's so sort of unconnected, and it's really not. There's great method to this global picture right here. But this is just a brief snapshot of some of the places that we work. And actually, there's some places that we work in sort of different ways, and then we've got a program in the Navajo Nation as well, sort of really thinking about, it's about health disparity, it's not about places in the world. And so this is where we are. I wanted to talk a little bit about where we are and what we do, just to do a dive, a snapshot. So Partners in Health, as I mentioned, is a healthcare delivery organization. So one of the ways that we do that, is to make sure that we work mostly in rural areas. And the reason is that our mission has within it something that we call a preferential option for the poor. We're actually looking, we are looking for the most vulnerable people, and they are usually not in capital cities. They're often in capital cities, but so are most of the NGOs. So we're looking in a way for the sort of the last mile, a group of people, a smaller percentage, hoping to change. It's a little bit sort of, if we can do it there in the most remote places where there are no systems and that kind of thing, we feel that it will also be easier to create systems that will go back to capital cities and bigger cities. So healthcare delivery organization, we work in 9 countries. Right now, we've got more than 70 sites around those countries. And when I say sites, I mean clinics and hospitals. And we have about 14,000 employees at this point. Many of those are community health workers. So many of those people are being employed for the first time. Many of those people are, the incomes that they are making are relatively small. Certainly they would be called a stipend, probably in most of the countries in which we work, anywhere from about $50 to $80 a month, but they're paid for their labor and they're trained and they provide a very essential service, because we feel that I was just sort of thinking about the way that we do it is that we're community-based. We work with the community health workers in the community, meeting people who are already sick and destitute, and then that feeds into a system of clinics, that feeds into a system connected to larger hospitals. That's actually how it should be done pretty much everywhere, including in this country. The things that are missing in some of the places in which we work are, some equipped clinics and certainly the tertiary hospitals. Tertiary hospitals are not what's missing in this country. The community-based care piece is missing in this country. Anyway, don't get me going. I won't be able to keep on time. But as I said, any of these things that I'm mentioning now, I know you won't be worried about asking questions about any of them. So one of the things that we do, as I said, is we rebuild the public infrastructure. So one of the ways that we've done this is going back to not creating parallel systems. We started off as a charity. The first clinic that we built in that little dusty settlement was a charity clinic. And then after a while, we realized that all of these people were coming to this one clinic, and it created these huge bottlenecks. And we said, so what's on offer around? Like, what is available to people? And we drove around, a whole group of us, including our Haitian colleagues, and we looked at what was available in the public sector. And the public clinics were, ramshackle, falling down. The people that worked there were often undertrained. There was no tools, and there were fee-for-service. There were all of these barriers so that they were empty. And they were all coming to this charity clinic. And we said, if we're going to make a sort of lasting change, if we're really going to have an effect so that it's not dependent upon charity, we will have to work with the public sector. We'll have to. It's definitely easier to work on your own. Keeping your head down, not trying to actually work with bureaucrats is a much, much easier thing. But this is what we did. So that's an important part of what we do. And training local people, as I said, to do that. The other thing that we do is we treat the social determinants of disease. That's another big piece of this. So, if your mission really is to take care of people living in poverty, and, folks come to the clinic. I have a great friend of mine who worked at Partners in Health years ago, and then went to medical school and became a doctor, and he had actually been to Haiti beforehand, and he said he was so excited after graduating from medical school to go back to Haiti. He spoke Creole. He sat down, he waited in the clinic, and he said, first patient came in, he said, how are you doing? Why are you here? What can I do for you? And she said, my house has no roof, and I sleep in the mud, or my children are hungry. And he sort of realized that with all of this training and all of these diplomas and all of this, and he could sit there, and there he felt suddenly this person was saying, we are sick, but it's not a disease that he thought that he had actually been trained to to cure. So what happened was a sort of a big realization within the organization to make sure that you can fit housing, access to water, food onto a prescription pad. I mean, there has to be a way to do this. That, again, you will receive a lot of pushback, mission creep, all of this kind of thing. Focusing on the mission is an important piece, as I will mention. You know, there's a list of different things. One of the things, I mean, just to throw it out, we're addressing maternal mortality in the places in which we work. We are treating cancer in rural Rwanda at the moment. And we've responded, as I mentioned earlier, to some of the natural disasters, some of the major crises that are happening around our sites, and also trying to influence policy. This is not, I'm not saying this in order to sort of sound grandiose. It's like we're covering everything. We're doing some of it not particularly well, to be candid. But what I'm trying to say is that these are all things that we have taken on, but when we started, we didn't know that we would have to do. I mean, so that the view, the landscape again, is that I can look back and say, gosh, some of these things we didn't realize we would have to tackle. So, and the reason for that is that, all of this has sort of changed as we've gone along, the vision piece, but the mission we had all the years back, and that mission was to create an option, preferential option for the poor, so you make sure that we're keeping our eyes on that piece if you're going to do that, and to bring the fruits of modern medical science to those who need them most. And we've added in there to provide an antidote to despair, which is again a broad thing, you know, antidote to despair for the people and the communities in which we're working. And also, in the end, if you think about it, if you really, really stop to think about this world, as an antidote to despair for all of us too. It's an important thing. And the antidotes that you see along the way are the obvious improvements, incremental, exponential, that I've mentioned, and many, many that I haven't mentioned. Sort of different snapshots of who we are, sort of where we are. This is my friend Paul Farmer, some of you might know, colleagues and friends in Lesotho working in a drug-resistant tuberculosis hospital in Maseru. You know, these are the kinds of people that you need. You need builders, and you need technicians, and you need educators, and you need community health workers, and you need social workers, and you need cooks, and you need lab techs. You need all of these things in order to do it. It's not one specific group or one skill set. You also need accountants and IT specialists. All of the things that I know that you know, and you also need colleagues, and often, if you're lucky, you need colleagues who are also your friends. This is an important thing, because whatever it is that you tackle, and I say this every year because it is key. Whatever it is that you tackle, you don't want to try and do this stuff alone. It's really, really good to do it with people that you respect, that you care about, you love, because if you are in it for the long term, which I hope all of you, whatever it is that you choose, can be in something for the long term, that you do it with a group of people that you respect, because it's complicated, it's hard. Anything worth doing, as I was just saying to President Bottomley, is complicated. And we were talking a little bit about education. Same thing. You know, the same big platform. So you need resources. You have to have resources to be able to do this, especially if you are what we refer to at Partners in Health, an O for the P organization, an option for the poor organization. If that really is your mandate and your mission, then you better have resources. You need to make sure that you are not vulnerable to the vagaries of markets, to, you know, the crises that go on. And it's a very hard thing. Wellesley College needs resources, of course. So does the Dana-Farber. You know, when you look at the campaigns and things that go on, there's a reason for needing resources. And so that's become obviously part of my work, and part of many of the people at this lovely college's work is to raise resources, because we believe in the important mission. And then you need to have access to the therapeutics and tools. You have to have that. You can't say, you know, we'll have little simple solutions for these complicated problems. We'll have a filter here, a pretend here. You have to say, okay, so what would it take to have a blood bank? What would it take to actually tackle some of the issues around maternal mortality and child survival? Access to modern obstetrics. What will it take? Oh, you need to have an OR. Oh, you need to have a blood bank. Oh, you need to have surgeons. Oh, you need to have someone who can do anesthesiology. And everyone's like, oh, we can't do that. Yes, you can. It's been done for many, 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 many decades. And you can do it in other places too. It's complicated, but you can do it. So those are the things. I scribbled a note to myself because when we built that hospital, that rather impressive hospital you saw in the second slide, I remember the passionate discussions that we had as we were, going through the money that people had entrusted us with to build this hospital and making sure that it was a modern hospital that raised the standards everywhere in Haiti. And we realized during the earthquake that I think it's the USS Comfort, had come down and provided fantastic, talk about comfort, fantastic care with, I think, 40 operating rooms. And they'd come down and been off the shores of Haiti. And we realized that the best hospital in Haiti at the time was that ship. And so, again, this is sort of aspirational. And we've called that hospital University Hospital of Mirbalais. HUM is the French acronym. And, and someone pointed out to me rather wryly the other day, but there isn't a university in Mirbalais. And we said, no, it's not yet, there isn't. But if you build things and call them, university hospitals, then it will be naturally raise the aspirations and expectations. That's something I learned from Paula a while back. So working through so doing all of that, yes. And, I know what I was going to say about that hospital. So and we had these passionate discussions about, running out of funds. And my medical colleagues in Haiti said, well, what about a CT scan? And I was like, a CT scan, but, we can't afford a CT scan. And we all said, sure we can. Again, it's like, if people say you can't afford one, you say, oh, okay, we can't afford one. Or you can say, how much does it cost? Why does it cost that much? Who can we do? Who do we know? How can we work with them? Why is it compelling? All of these kinds of things. Anyway, we have the first CT scan there. It's a fantastic hospital with all sorts of important modern equipment, a NICU, all of that, teaching, operating rooms. But, every time we walk past that room, it's the first CT scan in the public sector in Haiti. That's an important thing. And it's impossible to walk past that room, remember the trauma of getting it at the same time, but also how uplifted you feel when you are able to do that. And then, of course, what happens is everyone feels this great ownership for it. It's like, oh, is there a CT? It's like, wait, weren't you the one who said we didn't need one? Anyway, don't do that. And this is a little bit about how we do it. Again, I selected this image for lots of reasons because, it's impossible really when you're thinking about images to say, this is the reason, this represents this or this represents, like all of these images, they can represent many, many different things. They're like sort of Rorschach tests. This is a young woman who has cancer. She has an osteosarcoma in her knee. She's 19. And this is a physician, Dio, who's worked with us some time in Rwanda and here. And it's a beautiful photograph, which for me represents a great deal. It represents the fact that we take care of people with cancer. So this is not uncomplicated things. And this also represents a little bit about what we call accompaniment. But there are some concrete things about how we do it. So we do it through primarily building a platform in primary care, essentially. So again, back to not vertical programs, but actually saying that what we all need is access to care. And if you build a platform that's big enough and you provide the essential things in primary care, then you can also treat other diseases as well. You can mental illness, you can treat cancer, you can treat all of these things. You need extra things. But that's why it's important not to go in and say, oh, we're a clinic that only does HIV, or, which is how the funding streams are. But we only do this. But to say, here's a platform. On that platform, we'll take care of people. And there are certain things that have to belong on that platform. Vaccinations and women's health and treating STDs and all of these kinds of things, some things that are absolutely essential. And then you can you can pull on other things. And you have to, as I said earlier, you have to work through the public sector. So we've touched on that, but that's a very important concrete thing that we do. You have to also, in the end, leverage the service, this delivery piece, with teaching and with training. So with teaching and with research. So again, there's only so much any organization can do, you know, however well-meaning they are. I'm so glad that Nan has come back in just at the moment. I'm going to talk about teaching and training. It couldn't be better timed. So that's what you have to do. Even the most well-meaning delivery organization, which is Partners in Health, will always be small. We will always be relatively small, even though we want to make sure that our reach is big and broad. So you have to leverage it. That means if you are a small non-profit, as we are not set up to teach and train and do research. You have to make sure that you make partnerships with organizations and establishments that are universities and teaching hospitals, and create those avenues, work with them. That's something that my colleagues, not just Paul Farmer, but all of our clinical folks and medical students and researchers, they've all done this together, using some of the funding that is available, maybe let's say for one of those diseases like tuberculosis or HIV, and use that to make sure that you're training new doctors, training nurses, training everybody, technicians, and also creating the data so that you can actually make these important points and prove that it is possible and therefore impossible not to address it. And medical education, which we don't have time to go into, but happy to answer questions about it as well. So these are some of the concrete things, and sort of back to this picture of this young woman, there's the other sort of less concrete things that involve, that are harder to explain and harder to teach, but I know that you already embody a lot of these kinds of things. They're what we call accompaniment. We could also refer to it as pragmatic solidarity, but it involves sort of proximity. It involves sticking with something, someone, or a problem for a long time. It's relationships rather than or open-ended relationships rather than contracts. That sort of thing is really what we're talking about. And I like this because, you know, this is obviously a picture of individual accompaniment, and then there are also you know, this is a picture to show you actually this is in Rwanda, and this is a picture I took in the first hospital we were asked to work. This is a public hospital. It's fallen, as you can see, into disrepair, although there were patients that day when I went to that hospital. And this is the cancer ward that I was telling you about in northern Rwanda in the hospital in Butare. So, you know, really, how do you get from this to this? How do you raise enough expectations to say, we won't just replace the beds, we'll actually try to help the infrastructure and try to take it from this to not just an inpatient hospital, but actually cancer treatment? How do you form a relationship and a partnership with the Dana-Farber, which is where we have a great partnership? How do they send you know, their experienced oncology nurses out to train, because the burden of disease is so great? That young woman that you saw come in, who's 19, once they heard that this government hospital partnering with Partners in Health is treating cancer, we had tons of people coming into the hospital with, and she had a very late stage. So her cancer had already metastasized. She was 19, and we see these people all day, every day. So trying to get ahead of the curve is a very important piece of this. So these are the intangibles. You know, I think that back to the long view is an important piece. You know, not giving up, even though you want to at times, making sure that you can keep your eyes on the prize of what it is, going back to the mission of whatever mission you connect yourself to, making sure that you pay attention to that. Persuasion, you know, making sure that what you do as stewards, that you can actually be persuasive, that you can keep people interested, that you can change their minds, change their hearts, accompany them through any process as their skepticism, whatever it is. And then, of course, you know, imagination, as we touched on before and I talked about, there is a failure of it. So how can you make sure that your imaginations stay robust? And I thought in order to talk about that a little bit, and to talk about the connection between imagination and risk-taking, for example. You know, why is it that we think about risk-taking all of the time here, but we get back to low expectations? It's different when it feels like the risks are really about other people's lives. I think we get a little bit confused about what really is risky and what's not risky. What's risky is actually sometimes not to try something, or not to insist on doing something, or not to accompany people through things. So I thought I would take you back a little bit to how perhaps what parts of my life and what parts of your life and your lives can be connected to this. Well, you know, I don't think I was born as a risk taker or anything like that, but the backgrounds that you have and the fact that you're here at Wellesley and can take great advantage of that, and the opportunity that has been made available to you and will be made available in the future is a very important thing to grab hold of if you can. But that early socialization, this is like, I hesitated before putting these two slides together, but this is where I grew up in England, in a little village, and this is where Paul grew up in Florida. This is the bus that he lived in that used to be a tuberculosis testing bus, actually, when his father, you know, got it for a reduced price. So, you know, we're both interested in very, very similar things. I didn't know it at a young age, but you know, I grew up in this rather idyllic, bucolic setting in the countryside in just outside London, and he grew up here. You don't have to have had a certain background to have done it, but I think that having parents, for example, who were imaginative themselves, as I had, you know, very wonderful parents who knew how to fix things. And I think, but you know, my dad was a particularly good fixer. He wasn't a doctor, but when my brother had an accident, a very bad accident that required a new shunt, my father set to sort of doing that with a neurosurgeon and everything else. But so if you grow up in an atmosphere where you are socialized for success, or you're around people who say, oh, that's a bad problem, I think I can fix it. With other people, but I think I can fix it. It rubs off on you. And that's what I'm saying, sort of, you know, you don't have to have had you know, a parent who's interested in neurology to be able to do that. You have watched and grown up accustomed to seeing things fixed often. And you know, Paul's mother worked in a supermarket in Florida. His father was a high school math teacher. So very, very different, but both of us entirely socialized for success. You have been too. Take advantage of that. And realizing that it was probably that, you know, a bit of a spirit of adventure, and then being able to take advantage of all of those opportunities coming together. And one of the things that happens when you have parents who are able to fix things, or when you can face conundra that seem intractable at the time, and I'm sure that everybody personally is going to face difficult times, there's no question. But actually finding ways to come up with solutions is an extremely important part of the job. And what we are trained for isn't necessarily what we end up doing. So that one of the examples I wanted to give quickly, jumping from that slide, is, you know, this is a bridge, obviously a bridge. It's actually a Murphy bridge, I think is the name for it. And it doesn't look nearly as impressive as it should look, because it took us 6 years to get this bridge built. And you know, the reason that I feel filled with pride is that we had built a clinic over here as, you know, part of the public sector piece. We built a clinic, but it didn't have an operating room. And the hospital that we worked at was across this river and a few miles down. But we had an ambulance system, and we had the internet, and we had all of these ways. But at certain times of the year, and during rainy season, this river that doesn't look very dramatic here, but trust me, was very dramatic, swallowed up ambulances, all kinds of things, made it impossible for patients to get from their community, especially if they needed C-sections or anything else, across the river. So we had many women dying in labor, unable to cross this. And back to that idea of what fits onto a prescription pad, we said to ourselves, we're going to have to get a bridge built. And everyone was saying, you know, all of these sort of different development types, like, oh, it's going to be very difficult. You won't be able to do it. It was very, very difficult, very difficult. We tried, and it's very difficult. So you have to talk to the Haitian public works situation. You have to find engineers. Any engineers at Partners in Health? No. What about the UN? I think they have a bridge. Anyway, long story short, it took us 6 years to get this upholstery Murphy Bridge built. But the cars go across here and everything else. But, you know, when the river rises and all this, these are the sorts of things that you want to make sure that you can get done. So engineers are needed, and so are people that don't become so bureaucratic or so enamored by systems that when people say, but that's mission creep, isn't it, for Partners in Health, you can actually say, no, 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 it's actually not. This really fits very, very firmly. We are not saying at PIH or any of our partnership organizations that we have to do it, simply that it must be done. So if you can help facilitate some of these things as they become problems, that's a great thing. So that's, you know, in a way, that's a penultimate slide. And the last slide I want to show you, having shown you the hospital, the new tertiary hospital in Haiti built after the earthquake, with support, I know, from people at Wellesley and beyond, is you know, certainly a jewel in the crown for us, because it feels, I mean, you know, now of course the devil is in the details of how you keep a major hospital running, and running well, and making sure that everyone's being trained. But so, and this is the last slide I want to leave you with, connected to the cancer ward. Actually, this is the hospital that we built with the help of the government of Rwanda, the Ministry of Health, with other partners, with funders, with a small group of architects actually that started here in Massachusetts at the School of Design, one of the schools of design here, who came to a talk that Paul gave and said, well, he said, I'm an architect, but I love the idea of working in global health. How can I do that? Can I work for Partners in Health? And we said, well, why don't you start your own organization? So he did, and he started this group called MASS, which is a design and architect organization that raises its own funds. And they designed this hospital, and they have been doing other clinics and hospitals and schools ever since. But I wanted to show it not only because I think it's a very beautiful hospital, and the folks in Haiti actually sometimes, and the folks in Rwanda will compare their hospitals, how beautiful this one is compared to the one in Mirebalais. But so this is, I mean, these are parts of the rewards of what you can, when you apply yourself, when you look at the long view, when you raise expectations, when you change standards, when you know what your talents are, when you can take advantage of your opportunity. These are some of the things that you can do. And as you can see, global health is broad. It's not health in the narrow terms. It's health in a very it's in a much less clearly defined picture. And I think that what I'm saying to you is, whatever it is you do, make sure that it's very broad, and make sure that you always leave plenty of time for questions, whatever you do. Thank you. So, thank you. I know that I had sent a piece that Paul and one or two others had written in Global Affairs, really talking about aid effectiveness and how some of the things that we need to do to sort of shift paradigms and think about how aid might be delivered more effectively in this world, because there's plenty of aid and there's plenty of it being delivered. It's just done through this rather arcane mechanism. So we're sort of really thinking about how organizationally do you use your muscle and your experience over the decades to be able to sort of really define how it is. But I'm sure lots of you have questions on any of those things or anything else. So please, yeah, right in the middle.
Really, really interesting. In high school, I worked on a documentary on maternal mortality. And one of the things that kept coming up were these various religious and social taboos that complicated the delivery of medical services. For example, in the northern part of Nigeria, Islam is, the dominant faith, and women couldn't see a male doctor, for example. How do you think about that when you're operating in these communities, and when it's best to work within a taboo and when you just need to go right through it and change the mindset?
Yeah, interesting question. I think that one of the things that we have found over time is that sometimes it feels as though the provision of a necessity, say access to to modern obstetrics, for example, all of these kinds of things, some of the idea of taboos fall away. I don't mean that they're not really there and they're constructed falsely at all. I just mean that there are all kinds of ways to get around those, in terms of, if you think about them as other, not even a barrier, but it's not, for example, as though there aren't women clinicians or women obstetricians. And certainly for the folks that we work with, and in places like Rwanda, there are far more women doing a great deal of all of this work. So it's not that we haven't found the taboos anywhere that we work. It's just that I think that when you immerse yourself and you work, if you're accompanying well, you're not leading the charge with your own mores and ways of doing things. You're already kind of behind and actually asking the advice of the Ministry of Health, the local leaders, and various people already. So you can be guided as to the best way to do some of these things. And what I do want to say is that we haven't met anyone, for example, thinking about some of the stigma around HIV treatment, and how many people said to us, mostly in this country, not the patients themselves, there's so much stigma associated, you won't be able to get people to come to the clinics. And we found actually what happened is, yes, it's true, if you have a clinic that simply is for HIV, you might as well have a neon sign saying, STD clinic, come in here. I mean, you're not going to have a lot of people going there, particularly if there's also not treatment available. So once we found out actually it wasn't just voluntary testing and counseling, but there was actually treatment available. And once we embedded it into a larger hospital setting and not having a clinic, we actually found that taboo or that stigma actually completely disappeared. So it's sort of finding ways around it. Yeah, sure. Yes.
Hi, thank you so much for speaking with us today. I found the article and your talk very interesting because in the past few days we've been hearing from different lecturers and speakers who've been discussing the shortcomings of the public sector when it comes to building infrastructure, particularly because there can be corruption or that it's not as effective as the private sector. But you're offering a different perspective, so I'm just wondering if you can tell us more about your own experiences working with the public sector and what strategies you use in terms of approaching them.
Yes, and don't get me wrong, it's not at all that it's not difficult and complicated to do it. It really is, but I think that going back to the piece about what your mission is, and if indeed that's really where you connect and what it is that you're designed to do. The same with Wellesley College or any other establishment. Like what is it that you're designed to do? If you stick to that mission, that doesn't mean don't change as landscapes change. That doesn't mean stick to the mission that was set out here all of those years ago and don't change it to adapt. But it does mean, make sure that if those are the things that you believe in, stay true to those and adapt as the landscapes adapt. What we found, so if we are going to do that, what we realized is, as I said earlier, is that you have to work with the public sector if you want to make lasting change. And there are many reasons not to, but we found, I think for me, one of the important things is you don't have to know and like and appreciate every single person in every branch of a government or a ministry or anything else. You really need to make connections with perhaps one or two people that you know, either in local government, so district health officers, that kind of thing, and also it does help, of course, to have allies, but also that comes back to the persuasion thing, getting to know people. Most ministers of health, or most, what we have found is that it's very quick and easy to say, we can't work with the government, it's corrupt. We can't work with this, it's just too difficult. We can't really keep track of the money, we can't do this. So what about if you actually applied that principle of accompaniment, not only to person, but actually from an organization to the public sector. So, if you have, I'll give you a quick example. After the earthquake, loads and loads and loads of money were raised for many, many different organizations. The General Hospital in Port-au-Prince, which is the main hospital there, public hospital, was badly damaged, but there were still doctors who could work there and many, many other NGOs who were there. The Red Cross, the International Red Cross, had raised a great deal of money and wanted to give it to, we said, give it to that hospital. They need that money and everything else, and that they couldn't account for it. And they were worried about it. And we said, you know, again, this goes back to risk-taking. Is it worse to say, therefore, we cannot spend this money that we've raised on this because we're worried that there might be some corruption? Or could you go in and say, what do you mean by corruption? It actually ended up, it was things like there's no punch clock, there's no system involved for being able to do things. So if you actually get in, roll up your sleeve and say, actually, what is the problem? How can we help? Get to know one or two people and look at lifting those barriers. That's the kind of way it goes forward, rather than going in and saying, you know, here's the government, we better work with them. Oh gosh, it's a murky mire. I mean, our own government, it's tough, you know, it's tough. You know, any government, any big, large bureaucracy is designed that way. What is it that Weber referred to, the iron cage of bureaucracy? Systems are really very, very important for things, but don't let those systems trump actually getting stuff done. And that might mean going and having dinner with someone who works in the ministry, or going and understanding more and that sort of thing. That's the key to it as well.
Thank you.
Sure, sure. I'm going to go over here. Yes.
This question might be a little bit specific to me, but I think it has broader applications. I'm a Russian major, as anyone who talks with me knows. But I noticed on the map you put up that you do work in Russia, and I know recently there have been a lot of problems because of the government being very hostile towards NGOs and foreign-funded entities. And I'm just wondering, how do you address issues like that kind of institutionalized hostility towards foreign companies, foreign projects coming in and doing work?
Yeah. Well, I don't want to pretend that I'm a Russia expert at all. But again, I think it goes back to similar principles. Actually, we haven't been asked to leave Russia at all. I know a number of them have. And it goes back to that other principle about how you accompany the government. And we're working in Siberia, in Tomsk particularly, but we've been working for some time in the prison sector and the public sector on these, particularly drug-resistant tuberculosis. So we've been working there on projects around training and teaching, and we've had a pretty good relationship. So we haven't been asked to leave. We like working there. The burden of disease there is high, HIV and tuberculosis. Imagine, you know, being sentenced for a petty crime and going into a prison in Russia and coming out with a death sentence of drug-resistant tuberculosis. It's very, very tough, and it's very, very treatable. So that's what we've been doing there. And I think that, you know, finding ways, that the difficulty right now is that no US public funds. We can't accept public funds. Most of our work there is not supported by, it's very hard to raise money for a middle-income country, as you can imagine. Easier to raise it for Rwanda or Haiti. So we, you know, we relied very heavily on global fund money and on public sector here. So that's the difficulty now, because as we look at if we're keeping our eyes on the burden of disease, which is very high, if we want to capitalize upon all of those years of experience and thinking about the platform of care is there, and people were dying of this entirely treatable disease, and then and it will also be Hep C, for example, where new therapeutics are available. So we, again, the hostility, we haven't felt it directly to our colleagues. We in part, actually, I'm realizing this as I'm answering your question, we work with local nationals. So we're not an NGO there's no US person running an office in any of the country in which we're working. They're working there side by side often, but our Russian counterparts are doing the work there. We're simply accompanying them. So it's, as you can imagine, a different relationship straight away, rather than we've gone into Russia, we've decided we're going to help them, and we're going to decide how that's done. So then I think the hostilities are much more likely to occur. Does that, yeah, good, okay, good. Yes? How are we doing for time? Are we okay? Okay, good.
Hi, thank you for coming today. So my family's from Ghana, and I have an uncle who was trained in medical school in Ghana, and he now practices in the United States. And he's decided to come here because his kids have access to better education, he gets paid more. So you have these hospitals. How do you entice people to stay?
Yeah, the reverse brain drain is a way of thinking about it. How can we do that? It's very, very important, and I think it involves not just doing one specific thing again, but making sure that you're creating economic opportunity. One of the things that we've seen is if you invest in health in any of these places, the investments that you make in health will automatically transform the economic situation of the town in which you're working, because you're creating jobs, and which in turn is helping to boost livelihoods and that sort of thing. I think education is a huge part of what you're talking about here, and I totally confess, and on behalf of Partners in Health, it's an enormous frustration to us, because it needs to be done, and we have supported many different, small, not well-coordinated efforts around education for young people, for children, but making sure that there's that opportunity for the children, and then also making sure that you're connected to other universities. So there's, on the one hand, there's a question about your uncle's children and making sure that they can have an education, which I think is something, the education platform in these countries need to be addressed. Again, it can't be private schools that just mean it's impossible to go. The other thing is to make sure that there are opportunities for training and medical education in those countries, so that, while someone might, most of the countries, I don't know about Ghana, but certainly in Haiti and some other places, it's usually an undergraduate medical education of 4 years. And that's it, often without any kind of training, residency, postgraduate training, residencies afterwards. We were supporting the first ever residencies in Haiti, but doing it in conjunction with medical schools here, so that we can make sure that the residents, there's global health residents here through the Brigham Women's Hospital who go to Haiti and help to train, and then there are opportunities also for residents to come here but then go back. Most people, I'm guessing your uncle included, wouldn't prefer to be here if those opportunities were available. So it's really making sure that you can partner with the right establishments to make sure that those opportunities are available. And when we've seen that when the training is available for nurses, somebody told me, we work in Malawi too, that there are more Malawian nurses in Manchester in the UK than there are in Malawi, which is a huge, huge issue. When you start offering economic incentives, training, not economic incentives, pay for people, reliable pay, then that happens. I have to confess, though, that because of the places that we work are very, very rural, it is an issue, because many people are coming from towns, and then they have to sometimes leave their kids for the week, or one of the parents has to not work, or one of the parents has to have a job that they don't want in the city. So we're really looking at ways to work with the public sector to try to bolster that. But it's a great question, really important question. I'm going to zoom this way. Yes?
So thank you very much for being here today.
Sure.
My question is regarding your thoughts on nonprofits and NGOs, and how there are thousands upon thousands of them worldwide. And I think my impression is that some of the complaints of these organizations is that because there's a limitation of resources, there's also a limitation on the efficiency and the amount that you can sort of collaborate and organize on your own. And in the article that you had assigned, we read about how, there's sort of, referring to landscapes, I guess we can say, in a short term or in a smaller area, sometimes it's easier to solve those smaller problems with simply within those containments. I'm wondering if you think it would be really beneficial for NGOs and nonprofits worldwide to have some sort of body that facilitates these collaborations, really promotes this increased efficiency, just given the fact that there are so many organizations around the world that are many times working for the same goals.
Yeah, I mean, I was totally with you until you said another body of, and then I suddenly thought, oh no, one more body, one more layer of bureaucracy. But I think that you're onto something. My sense, though, is if we could persuade, and just to be clear, there are many fantastic NGOs out there. There really are. I mean, and many that we're lucky enough to work with, and many of them, like us, striving to get better at things. This is entirely something that we continue to work on every single day. So it's not that we've cracked a code. It's just that we think that there are ways to do it, and the aspirational piece is to get better by doing certain things. And I would say the most important thing that we could get NGOs to do, which they're reluctant to do, is to work in the public sector. Because if we can get them to do that on the small scale that you're talking about, so even if it's sort of being able to look at a district, to work in a small geographical area like a town somewhere, and then look at who's in charge of the health indices there. Who has access to a budget there? How can you work with them? What is it that they need? Don't come in and say, we've determined in Washington, D.C. that you guys need latrines and da-da-da-da-da-da. Say, what do you need? And sometimes that person, a man or a woman, will say, we need a wall around it. And you say, oh, good Lord, you need a wall? And then but then you talk about, why do you need a wall? What's it for? And how can we help? And yes, so seed a little bit of money for the wall. And then you make friends, find out why. You know, he wasn't saying, I need a swimming pool. So I think it's trying to persuade people to work with unlikely partners, people who they're not generally thought to. But, you know, certainly connecting and tethering groups to each other is a very important thing. It's being done with actually quite some success by President Clinton through the Clinton Global Initiative, for example. It's not a body that regulates. And truly, I just worry about, you know, if it's another big worldwide regulatory body, but, you know, when actually it should really be sort of, you know, invitational from the governments. We'd like to work with this group because we know that you're respectful and you'll work with us and you'll help us, and that sort of thing. We were asked to do some things we didn't want to do, for example, necessarily want to do in Rwanda. They asked us to work on their health insurance system. We said, we really want to lift those fees. And they said, it's actually a small fee, and this is how we want to do it. So we looked at actually what the barriers to those fees were, which might have been actually even just getting a card, a health insurance card, which involved a photograph and lamination. So we got a photographer in and took pictures of all of them and laminated the cards ourselves with them, with permission from the locals and the local government, and handed them out. You know, there are ways around these things that can become, you know, bureaucratic hurdles. So I would sort of urge the other piece, but certainly some regulations would be great, because these are just, you can go in anywhere, like you can hang a shingle for various things. It's important to regulate things, just important that we don't get so caught up in regulations that we don't see the forest for the trees. Okay, one more question. Joanne, you choose. I can't choose one more question. Yes.
Thank you so much for being here. You talked quite a bit about trying to prevent failures of the imagination, and I feel like that's something that's come up throughout the week, talking about how we can imagine a better future. And so I was curious, in your projects, in a very tangible way, do you find that you tend to draw on existing models in, say, more developed countries? Do you find you tend to try to imagine a better future? Do you draw on literature? What do you find works for you and your team?
All of the above. That's a lovely question. I think it is, you know, as Fiona mentioned earlier, sort of the remaining open and making sure that you have, I think to be creative or imaginative, you really do have to have some space to do it. Academics, to some extent, academics create time to make sure that they are reading and writing and all of this sort of thing. I think in our very busy lives, I know I'm talking to the right people about this, I bet that you're busy all the time, or feel like you should be busy. I'm doing this, you know what I'm doing. And creating the space to actually allow yourself to think creatively or to be imaginative, and not filling it, is a very, very key thing. Reading novels, certainly. Don't just read dense articles about what you think you should be reading about. You will have fantastically wonderful, inspiring thoughts because you read a piece or a piece of poetry, that sort of thing. Talking and connecting to a group of people who are like-minded is very helpful too, because you will inspire each other to think about things. Your circle of colleagues, your family. I do think, though, that probably the most important piece is making sure that you do keep some room to think, keep some room to do that, because you have to have the information and then you have to have the space available to do that. And that's a hard thing, I know, for all of you to do, but I would urge you to do it. We had a bit more of it, I think, a few years ago. It was a little easier to create that time. But certainly, you know, this environment, this campus, one of the things that I found that it did very well was to create, talking about landscapes, I think somehow not being in the center, in the hub of a busy city. Do take advantage of this. I don't know where you'll all end up living around the world, but take advantage of the quiet here to create that space too. It's a noisy world. Yeah.